Hello, I'm Thomas Prebet from Yale Cancer Center, and I've been asked today to discuss with you how we can potentially monitor patients with HMA and venetoclax combination therapy in the context of acute myeloid leukemias. As most of you may know, the addition of venetoclax to the armatorium of treatments for acute myeloid leukemia has been a pretty significant game changer. That also means that we need to adjust what we do as compared to a regular hypomethylating agent therapy, either as a cytidine or decitabine. And I think we can potentially articulate this monitoring in two different sections. The first one is the monitoring of the safety of the combination. And that's probably the most important. That's where we have the most significant changes as compared to what we know from the conventional hypomethylating agent-based therapy. A combination of HMA and venetoclax works faster and potentially is more myelosuppressive than most of the conventional hypomethylating agent regimen. On the short term, we know that with the combination, we can have a risk of tumor lysis syndrome, which is not something we classically see with AZA or decitabine. The recommendation based on the clinical trial, the VIAL trial, is to have this patient admitted for the initial few days, just to make sure that we don't see any tumor lysis syndrome, and also importantly, to try to have a reasonable control of the total white cell count before starting therapy. So during these first few days, that's going to be really monitoring all the classical signs of tumor lysis syndrome that you can think about: potassium, creatinine function, uric acid, and make sure that we don't get the patient in trouble. Based on the VIAL data, that's roughly 10% of the patients that would develop some degree of tumor lysis syndrome despite this prophylaxis. So that's really something that is important, that during this first week of treatment, we have a really close monitoring of these labs. During the first cycle of treatment, we also see a lot of myelosuppression, a lot more than what we expect from conventional hypomethylating agent regimens. And we need to be prepared to have more transfusion needs. And so we need to basically also ramp up what we usually do from a safety perspective, and maybe increase the number of blood draw each week for this patient. We also know that this myelosuppression can be something that can last for quite a bit. And it's basically an expert's recommendation to include in the monitoring of this first cycle a potential bone marrow biopsy at the end of the first cycle if the blood counts are not fully recovered between day 20 and 28. If the bone marrow is empty and does not show any signs of residual disease, this will be a good situation to potentially hold the venetoclax until count recovery and until the start of the next cycle of treatment. If there's some persistent disease, in that case, the recommendation is to maintain the venetoclax and start the second cycle of treatment as expected around day 28. On the long run, we know that patients treated with venetoclax will experience more cytopenias also. And we may have to make some dose adjustment of the venetoclax based on the degree of cytopenias that we will see in our patient. That's for the safety monitoring aspect. From the efficacy of treatment standpoint, as I was mentioning, we are evaluating response to treatment pretty early, usually after the first cycle of treatment, or in some cases after the second cycle of treatment. We know that a significant number of patients will experience response, and we know that the majority of these patients will experience response during the first 3 cycles of treatment. even if there are some late responder that may respond between cycle 3 and cycle 6 of treatment. Most of the physicians with a good experience with a combination of hypomethylating agent and venetoclax will probably treat the patient for at least 4 cycles of treatment before really considering the patient for another therapy if we still see some active disease. But luckily, thanks to the results that we see with this medication, we know that a majority of the patients will have a good response from the get-go. Nevertheless, we need to be vigilant and know that after a year or 18 months on treatment, we definitely see a significant number of relapses, and combined monitoring of the blood counts and the bone marrow evaluation are of paramount importance in the monitoring of these patients. One of the hot topics of research right now is what do we do with really minimal amount of disease? And this question about measurable residual disease, MRD, is right now without any clear answer. But we know that one of the big difference we see for patients on HMA plus venetoclax is the fact that we can achieve a real negative MRD status for this patient, which is something that was really elusive for patients treated with just hypomethylating agent. And so, to summarize, the first few weeks on treatment are really focused on the monitoring of safety of this combination, risk of tumor lysis syndrome, a significant risk of myelosuppression with cytopenia that can be long-lasting, that may require to hold the treatment for a while. And from the efficacy standpoint, remember to have this early evaluation of the bone marrow biopsy after cycle 1 or after cycle 2, and to have regular evaluation of the response, especially if you see cytopenia that may be either toxicity of the treatment or a potential progression of the disease. I'd like to thank you for your attention.